Yes, welcome. Should I go ahead? All right. Well, Happy New Year, everybody. Welcome to the first event of the OR Steering Committee for 2021. So glad to have you here. Today, we're speaking about diverse communities and COVID-19, and it's sort of twofold because it is how we are addressing the needs of diverse communities through OR efforts, but also doing all of our pre-pandemic OR efforts now to serve diverse communities and really thinking about the diversity in diverse. My name is Crystal Glover. I am a social psychologist and mixed methodologist at the Rush Alzheimer's Disease Center. I also serve as our OR core leader and the OR Steering Committee chair. So it's great to have you here. We have four great panelists here today, Dr. Jason Flatt, Dr. Carrie Gleason, Dr. Joyce Balls-Berry, and Dr. Sophia Wang, who's on the phone for now. They will have about 9 minutes each to speak about different efforts in different communities. And then at the end, for about 20 minutes, we have an open panel. So everybody together, question and answer. Please use the Q&A box for any questions that you may have for the panelists. I will be monitoring that and making sure that your questions can be posed to the panel at the end. This session is being recorded, so in case you have to jump off or want to look back later. So thank you. Thank you for being here. And we have our moderator, Dr. Corinne Pettigrew, a new OR Steering Committee member. And Corinne, would you like to say a few words? Thanks, everybody.
Sure. Thank you, Crystal, and welcome everyone to our first webinar. My name is Corinne Pettigrew. I'm an assistant professor in neurology, and I lead the OR core for the Johns Hopkins Alzheimer's Disease Research Center. And as Crystal mentioned, I'm also a new member of the OR core steering committee. So I'm really excited to be involved in these efforts. So as Crystal mentioned, we have a really exciting lineup with four great speakers, and because we have a packed schedule and want to allow for sufficient time for discussion, we'll jump right into the first speaker. So our first speaker will be Dr. Joy Balls-Berry. She's an associate professor of neurology at WashU School of Medicine, and she leads the Health Disparities and Equity Core at the Knight ADRC. Joyce, if you could please share your screen and take it away, that would be great.
I am making sure that this works. Good morning, everybody. So just bear with me while I prepare to present. Okay, and hopefully you all can see the slides. Good morning. My name is Dr. Joyce Balls-Berry, or Joy. I'm named after my mother, so I have a tendency to use my nickname. Both professionally and externally, which is Joy, and my last name is like a bouncing strawberry. So I am delighted to be here today, and I'd like to thank Dr. Glover for the gracious invitation to provide a little insight about COVID-19 and diverse communities, especially as it relates to the African American and Black perspective. So I don't have any disclosures right now, but hopefully one day in life I will have them. And that means that we're doing really well for the lab once those happen. So, so I will move on from there. So my plan is to examine the historical context of health disparities as it relates to COVID-19 in the African American and Black community. I am a psychiatric epidemiologist and a health educator, so a lot of times I like to present some of the epidata as it relates to COVID-19 and African Americans. And then we'll talk a little bit about vaccine hesitancy and then think about some of the next steps as it relates to eliminating COVID-19 disparities in African Americans or Blacks. So I want to start off with a case. And I'm going to start off with a quote from Dennis Murphy, the hospital CEO of Indiana University Hospital. And in a statement that was released when Dr. Susan Moore died, he said this: "I'm deeply saddened by her death and the loss her family is feeling. But is this enough? Is this enough for a woman who has dedicated her life to caring for others? Is this enough for a Black mother? Is this enough for the patient she leaves behind? So let me put it in a context. Dr. Susan Moore is an African-American woman. She was 52 years old at the time of her death. She died approximately 1 month after being diagnosed with COVID-19. She did not receive the care that she deserved as a patient, as a woman, as a representative of the healthcare community. She owned her own family medicine practice, and she left behind not only her patients, but her 19-year-old son. In a video that she released from her hospital bed, she detailed the misdiagnosis, the lack of care that she received. And when you have time, I urge you to look at Dr. Moore's story. This quote from that video stuck out for me. Dr. Moore said, "This is how Black people get killed, when you send them home and they don't know how to fight for themselves. I had to talk to somebody, maybe the media, somebody to let them know how I'm being treated up in this place." A week later, or actually a couple days later, or I think it was even hours later, she was released from the hospital, went to another hospital, and died there from COVID-19 complications. When we think about health disparities and social determinants of health, it always goes back to those that have and those that don't have. So the haves versus the have-nots. It's about where we're born, how we grow up, where we live, where we work, and even our age. It is about distribution of money, power, resources, and even the global, national, and local levels, and how we're impacted and how we're treated in terms of our health, our access to health, and opportunities for overall wellness. And we must keep in mind that health disparities doesn't always refer to all differences in health, but it's a term that we use often here in the United States to refer to specific differences in health or things that might impact our health and even influence healthcare policy. So I started with Dr. Moore's story, but I also want you to take into context the story that I have as well. I have lost family members to COVID-19. I've lost loved ones to it, colleagues to it, all who are Black, many of which are in an older generation who are over 45. I lost a cousin who was 60 years old to the disease. And many of these deaths were preventable. So when we're thinking about healthcare disparities and opportunities to improve health, we also must take into context historical trauma and even racism. And we must use the terms and call them by their name. Because I think many times we fear using the term racism when racism does impact healthcare, it impact the care that I've even received as a patient. It goes back to our history, and even that history impacts current practices in biomedical research. It impacts current practices and access to care. It goes back to historical mistrust. It goes back to humanity. Are we treating people and patients like humans? Are we really listening to them? It goes back to biomedical ethics and thinking about the principles of protection, not just HIPAA forms and things like that, but it's thinking about justice and making sure that we're not doing injustice by not providing the care that is needed. And then it's really thinking about how do we change it? How do we know that we're living in the shadows of historical mistrust, of racism, of a lack of care? How do we move forward from that? So I always say that we start with the community and patient engagement and research process, where we listen to community members, we understand their needs, we listen to caregivers, we listen to patients, and we involve them in changing the system. But we really have to change the system. So we are living in what I call the shadows of mistrust. Dr. Sims was the father of modern gynecology, and he did experiments on Black women who were slaves who had no opportunity to say no or provide informed consent. Mrs. Henrietta Lacks was also a participant in research, and she did not have the opportunity to provide consent, and her cervical cells were harvested without her knowledge or her family's knowledge, and those became the HeLa cells. Many of us know about the Tuskegee syphilis experiment, which looked at the natural progression of syphilis disease in African American men, and those men were not provided treatment even once penicillin became available. And then in my hometown of St. Louis, Missouri, the Cold War experiments were done in neighborhoods that had poor Blacks and poor whites. And those communities were not asked if they wanted to participate in those experiments. And many people died as a result of the chemical warfare that was done in those communities. So it goes back to lack of access, everyday racism and discrimination, lack of culturally appropriate care. Do our healthcare providers understand the communities and the context of those communities and where we come from and that history? And then it's thinking about misdiagnosis and even having a remembrance of misdiagnosis because we weren't listened to. And then it's even about the myths that are shared about different diseases. So when we think about COVID-19, we always have to take into context that this disease is linked directly for some to comorbid health conditions, which perpetuates the likelihood of either a poor course after diagnosis in terms of healing, or even leading to premature deaths because of COVID-19. So 60% of African Americans are likely to have diabetes, more than our non-Hispanic white counterparts. 42% are diagnosed or are new cases of HIV. A little less than a quarter are more likely to die from heart disease than our white counterparts. And there's even a higher prevalence of asthma. And then we are also 1.3 times more likely to be obese than our non-white counterparts. Taking those things into context, with the diagnosis of COVID-19 is a recipe for premature morbidity and mortality. Another thing to consider is what they call density. That's how many people live within a neighborhood or within a community. And there's been studies by Dr. Cyrus who found that there was a direct association between African American neighborhood density, the number of African Americans that live in a space together, and the prevalence of COVID-19. So the more dense the community is, the more likely the higher the prevalence of the disease. And then you add the comorbid health conditions on top of it. So when we think about testing for COVID-19, I'll put it in context of my hometown, St. Louis. At the beginning of the pandemic, there were not a lot of places for African Americans within our community to be tested for COVID-19, which then led back to access in these high dense communities, which meant the prevalence was higher. And in St. Louis, Missouri, the first person to die from the vaccine was a Black woman. I mean, died from the virus, not from the vaccine, Lord help. From the virus was a Black woman. We haven't had any deaths from the vaccine. I apologize for that misstep. So that leads us to think about what we call vaccine hesitancy. Are people afraid to receive the vaccine? So a study that was done by Dr. Jagdish, a colleague of mine we did our PhDs together. He found in a national sample of over 1,800 people that vaccine hesitancy was higher among African Americans, Hispanic, and those that had children at home, those that lived in a rural community, and Northeastern United States residents, and those that had a political affiliation of being Republican. And this was perpetuated by a pre-existing indecisiveness about vaccine, the thinking about the historical underpinnings and mistrust of the healthcare system, especially among Blacks and other minorities. Then thinking about the concerns related to cost, where we know that the vaccines are now being given for free, but there was a concern of the cost. And then a level of awareness, which relates to health literacy around the vaccine and even research literacy. Well, what does it mean that the vaccine is efficacious? So there are some recommendations that I have that I think will be pivotal as we think about engaging others in a dialogue around vaccine for COVID-19 and even around testing for COVID-19, is it starts with listening to the community, listening to their concerns, listening to my community when we say that we're unsure about why certain things are appropriate for us. But it also goes back to diversifying the workforce. Are we seeing physicians and nurses and other members on the care team that come from our communities? Is there a standard practice? Are we developing programs that address health disparities, especially as it relates to COVID-19? Are we hosting, as academic institutions, are we hosting trainings around cultural sensitivity, cultural humility, and vaccine hesitancy, and even testing concerns? Are we using what we call community patient engaged frameworks, where we involve the community and patients and even caregivers in the design process of these trainings, of preparing the workforce to work with us? And are we creating a shared vision with stakeholders to think about how do we increase opportunities for vaccination? Uh-oh. So there are some trusted sources of health information for African Americans. Many times it's going back to our faith-based communities. So like the churches and mosques and other places of worship. Even in my own research, we found that barbershops and beauty salons were another source of health information, and where people will actually have open dialogues about health. Our employers, even the school system, even for families that don't have kids in school, is another opportunity to engage. Philanthropic and social organizations like sororities and fraternities. I'm a proud member of Alpha Kappa Alpha Sorority Incorporated. So my sorority does a lot of work around topics related to health, and even making sure we have racially concordant care, which means having healthcare providers that come from our community, that look like us, that understand us. So the NAACP has a coronavirus response and advocacy resource. I'm going to click on this so you all, and hopefully the resource will pop up. Did it pop up? I just need a thumbs up. It didn't show.
No, Joy, one more minute if you would.
Okay. Thanks. So, and then there's also the National Pan-Atlantic Council for the COVID response. And then there's another thing called the racial equity tools, which is related to racial and equity and social justice resources as it relates to COVID-19. And so today, I hope that I provided a little bit of detail about the historical mistrust as it relates to COVID-19 within the community in which I come from. I wanted to acknowledge the disparities in COVID-19 as related to morbidity and mortality. And I wanted to encourage each of us to listen more. I'd like to thank Dr. John Morris for the opportunity to be the inaugural lead of the Health Disparities and Equity Core at the Knight ADRC. Also, a big thank you to our faculty and staff and the learners that we have in the Knight ADRC. And if you'd like to reach me, my email is listed here. And then I am very active on social media. So my Twitter handle is there, as well as Instagram. Keep in mind that those are my private platforms. So sometimes I post about other things besides just science. So sometimes I post about food. So I hope that I can see you on social media. And thank you again for allowing me to present.
Thank you. Thank you, Joy, for your insightful presentation, for the background, the strategies, and the resources, and for kicking off our webinar today. Just as a reminder to the audience, please use the Q&A box to leave questions for the panelists, which will be addressed after all 4 presentations have gone through or have completed. Next up, we have Dr. Jason Flatt, who is an assistant professor in the social and behavioral program at the University of Nevada in Las Vegas. And he's also affiliated with the Lou Ruvo Brain Health Center. And you'll also notice that there was a poll that popped up on your Zoom screen. So please answer that in between presenters. In the meantime, Jason, the floor is yours.
All right. Thank you so much for that introduction. So today I'm here to talk with you about concerns for the LGBTQIA community, and I'll explain the terms in a moment, but I really wanted to think about our community in terms of COVID-19 and what we should be considering. And I think Dr. Ballsbury really raised a lot of similar points that we should be thinking about for other vulnerable groups in terms of COVID-19. So to start off with some terminology, I wanted to just explain what I mean in terms of the LGBTQIA acronym. So when we're referring to this, it's important to realize that these are communities are brought together because of some of their unique differences. And so we can think about these terms. You may have heard from the NIH, the term sexual and gender minority. So this is an umbrella term where it refers to pieces like individual sexual orientation or their gender identity. So I'm using terms like lesbian, gay, bisexual, queer to refer to individuals whose sexual orientation is something other than heterosexual. So same loving individuals or people whose sexual orientation may vary on that spectrum. I have an image here showing you the gender unicorn, just to give you an idea of sort of a range of sort of identities that fall under this. So we can think of gender identity in terms of people who do not identify perhaps with the sex they were assigned at birth. So this would include individuals who identify as transgender or non-binary. We also can think about sex assigned at birth, and it's important to realize that across the spectrum, we often think of it in terms of binary, like male and female, but actually there are individuals who are born with differences in their sex development. So this includes people who identify as intersex. So I'll be using these acronyms today, but I wanted to give you this resource to kind of help guide you when you're thinking about the terms I'm using in terms of, are we thinking of it of gender identity, expression, sex assigned at birth, physical attraction, or even emotional attraction. So yes.
Sorry to interrupt. We can see the presentation mode where we see the preview of the next slide.
Oh, okay.
Can
Sorry
you
about
swap
that. Yeah, I'll swap them.
Thank you.
Thank you. Let's see. How does that look?
Perfect.
Is it the same?
Yep.
Okay.
Nope, that's great.
Okay, thank you. Sorry about that. So I wanted to just emphasize the population that we're all serving through the ADRCs in terms of older adults. So I'm often hear from colleagues, this is a small percent of the population, but when we look at this nationally, it's actually quite large. So currently we know there's over 2 million adults who identify as LGBTQIA+, who are age 50 and older. And when we think about it in terms of people who are 65 plus, it's over 1 million. As well, we know that this community is quite diverse. We think about it in terms of intersectionality in identities, but we know that at least 1 in 5 LGBTQIA older adults identify as a person of color. So it's really important to understand that there are very diverse needs for this community. When we look at them in terms of the numbers, I wanted to point out that there are some unique concerns for the community, especially in terms of access to care and services. So we know that LGBTQIA people are more likely to be single compared to their non-LGBTQ peers. So this can create unique challenges when we think about access to caregiving or broader resources that our relationships may provide for us. As well, we know that they're less likely to have kids 3 to 4 times. So this can also limit challenges when we think about accessing care, barriers, access to caregiver support. Many of those can be challenges. We also know they're more likely to live alone, which can be an especially concerning right now with the stay-at-home orders and people being socially isolated more. We also know that they're less likely to access healthcare services and disclose their identities when they go to access healthcare. One of the unique challenges for this community is around experiences of discrimination in healthcare settings. It wasn't long ago that identifying as a sexual minority person, LGBTQ, was considered a mental health disorder. And it wasn't until a couple of years ago that they finally took out being a transgender person was considered one of the DSM criteria for having a mental health problem. So because of these histories for this community, they're much less likely to seek out healthcare because of these fears. When we think about it in terms of COVID-19, it's quite concerning for this community. First, there's already distrust of the healthcare community. So this community may be more reluctant to seek out care or even consider getting the COVID-19 vaccine. We also know that with the stay-at-home orders, LGBTQ plus people are much more likely to face physical and mental health challenges, and so isolation can be quite discouraging for them. Also, we know that there's a greater need to reach out to this community right now, especially with knowing that they're more likely to live alone and be socially isolated from others. The other concern right now with COVID-19 is really to think about the community's history of experiencing trauma, discrimination, and other adverse experiences when they're accessing healthcare or aging-related services. So I want to encourage you to think about some of the trauma-informed care work that's been done, think about reaching the community where they're at, and especially right now, we're seeing concerns for our community, those who have lived during a time when we had the HIV/AIDS epidemic. And so this can re-trigger some of that trauma right now with the pandemic, and the community's quite concerned about being able to access resources, but also access care that's going to meet where they're at and be respectful of who they are. So these can be some especially unique challenges right now when we think about COVID-19 or broader aging services. So I wanted to share just some tips and resources if you have an opportunity and you know that you're interacting with LGBTQ plus older adults. Think about, encouraging them to stay socially active when it's safe, encouraging them to think about setting up some support systems right now. That might be a contact person or a buddy, encouraging, social interactions that are virtual. Have them think about creating a plan right now in case they do get a COVID-19 infection. It's especially important that they have these resources. So having a list of contacts, potentially considering having an emergency home quarantine kit. That way they have enough food and medications in case they're not able to leave, as well as thinking about their support system. So often for the community, they rely on their chosen family. So these may be friends or helpers. And so it's really important right now that the community think about reaching out and leveraging a lot of the resources that have been built within this community. I want to point out that this community is especially resilient. They've overcome many challenges over their lifetime, and it's important that we also turn to them to identify solutions that they know will work versus us coming more from a top-down approach. So I then want to just share some resources that you may be able to share with your patients or any loved ones. Here are some of the resources. SAGE, Services for Advocacy for LGBT Elders. They right now have a hotline, as well as they're doing quite a bit around virtual connecting. So Sage Connect is a new program that seniors can sign up for. They'll get connected with someone and they can engage in weekly phone calls or at a timing that they would prefer. There's also some resources for caregivers that have been tailored. And so I know that right now during the pandemic, it's especially hard on caregivers of LGBTQ elders. So it's important to think about resources for them. I also want to highlight the Institute on Aging's 24/7 friendship line. So I give the 800 number here. This is a great resource just to connect, but also have it for seniors who may want to reach out to others. There's also some other resources to consider. So CenterLink is a program that is supporting 186 LGBT centers across the country. So if people are looking for services that are tailored for them, this is a great resource to find those centers. There's also the Diverse Elders Coalition, which has been focused on LGBTQ elders for quite a while, and there's some great resources around COVID. Finally, there is some other national resources. There is the Trans Line, which is a resource that transgender and gender non-binary individuals can reach out and find out about healthcare options. I want to encourage the Trans Lifeline as well. And then there's also the Elder Locator program if people are looking for resources. Finally, one of the great resources to find out about healthcare that is welcoming and inclusive to this community is through the Human Rights Campaign. So people can search for healthcare facilities and look at their scores to ensure that these are more welcoming environments. So finally, I just wanted to thank you for the time. Here I give my email and a website with my research. I definitely want to encourage you to share the SAGE hotline. And I look forward to answering your questions a little later. So thank you so much.
Wonderful, Jason. Thank you for your presentation and for the great overview of some of the concerns, tips, and resources for this community. Our next presentation is going to be by Dr. Carrie Gleason. She's an associate professor at the Division of Geriatrics and Gerontology at the University of Wisconsin School of Medicine. And she also leads the Inclusion of Underrepresented Groups Core at the Wisconsin ADRC. Carrie, please go ahead.
How are the slides show up okay?
Yes, you're good to go.
Great, okay. So thank you, Dr. Pettigrew and Dr. Glover for the invitation to be part of this all-star panel. It's a real honor. I wanna talk about a project that we have going on here at the University of Wisconsin's Alzheimer's Disease Center. But I first wanna just, full disclosure, I'm not part of an OR core. Like Dr. Balsbury, I'm part of a core that's dedicated specifically to inclusion of underrepresented groups. So I'll say this, that I'm OR core adjacent, and I'm a big fan of the OR core. I'll put it that way. So with that, I'll tell you about an idea that had its genesis during one of our meetings with the Black Leaders for Brain Health. The Black Leaders for Brain Health is one of two advisory groups we have here for our Inclusion of Underrepresented Groups Core. So back in April of 2020, we were obviously had a lot of questions around COVID during our meeting, and a lot of discussion, and a lot of questions about what's true and what's not true. I brought up the fact that we were getting updates from our university and from our School of Medicine and Public Health, and that there were some new funding opportunities related to COVID. And I made the point, something to the effect of that's not my area, so I'm not, proposing anything in terms of grant funding. And I got asked this question of, well, why not go after resources that benefit our community? And it really it was one of those moments where you kind of say, aha, or maybe this is, ask yourself these hard questions about like, well, why am I holding back here? So the Wisconsin Partnership Program is an internal funding program, and they put this call out specifically around addressing COVID. It was really non-specific, so anything related to COVID. So we thought about the resources that we have within our center, of course, are relationships. So we had existing relationships with the Black community. We had existing relationships with the Oneida Nation of Wisconsin. This is Chairman Tahassi Hill giving a COVID update. You can see he wears his mask during these COVID updates. And we recognized pretty early on, the communities were hearing this, they were living it, that the Black and Latino community were affected And then subsequently, we learned how the Indigenous communities were being affected at a greater extent than other communities. So it was really on the forefront for our advisors and for our participants, and really the people who we are really trying to serve with our Alzheimer's disease work. So the idea came about to, maybe put in for some funding to help communicate accurate information around COVID, to translate what we're getting at the university to the community. So I assembled a leadership team. I call them the All-Stars. These are my co-leads for co-principal investigators, Dr. Maria Mora-Pinzon and Melissa Metaxen. And we put together a proposal to bridge that gap between what the university investigators know, or the information they're getting, the up-to-date information, versus what's out in the community. So we asked ourselves the question, like, how best do we get information out to communities? And the model of a social influencer came to mind. So social influencers, you oftentimes hear about this within social media, but social influencers exist in other more organic ways. So Dr. Ballsbury talked about churches and barbershops. Those are our social influencers as well. We know that social media and basically the megaphone that social media gives influencers can spread a lot of disinformation. So why not turn it on its head and actually begin to think about how social influencers and maybe social media can disseminate accurate information? So we developed a model, again, first acknowledging that there's a gap between information at the university level versus in the community, and how best to bridge that. We decided to set up infrastructure with the funding, including a scientific and medical advisor committee, as well as communication digital media specialists. So the infrastructure supports those individuals. It also supports our influencers. And this is where we really went out to recruit our social influencers, try to select the right people. And each community identified within their own resources and connections who might best fit that. Venus Washington joined the team of influencers. She had a fantastic social media presence. She had a Twitter account. She was active on Facebook. Basically any platform you can think of, she was very active. What we needed to do for Venus was then to give her the support to begin to put out COVID messages. Sasheen Lawrence from the United Nations had a lot of connections. She was not as active on social media. So keep that in mind when I show you some data later on. So she did not have much of a social media presence, but she had connections to key resources within the elder community as well as the health community. The Latino Health Council, when we approached them for this partnership, they preferred instead to actually take the money not to support a person, but a team of individuals. They also were very active in social media. So the communications team really provided the glue. So I feel incredibly fortunate to be working with these two individuals. George Levy is a communication and marketing specialist. He comes to us with a strong graphic design and basically has the know-how to create many of the beautiful posts that have been created. And Ornella Hill is a communication and journalism specialist. So help us think about more deeply about how the message gets communicated and what will resonate and based on basically the literature and what is known within the community. Our social influencers were basically, we put out very clear parameters about what was expected. We asked them to do some activity weekly. It might be a post or a tweet or a video, but it could also be something as hands-on as a newsletter. So Sasheen, for example, put out newsletter and postcards with meal delivery. So it didn't have to be a social media influence, but the social influencers could think broadly about how they might send a message. We also asked them to reach out to 6 of networks throughout the year. So, and this actually turned out to be exceedingly important. Those networks offer a way to sort of accelerate or amplify messages. So at least 6 networks at some point over the course of the year. Most have actually done more than 6 by this time. Here's an example of a YouTube video. I didn't plan to play it, but you can Google this to look it up. This is Venus Washington interviewing Dr. Jasmine Zapata. And you can see from the plants in the background, this was late fall that this came out. So the vaccine was not yet being distributed. But naturally, as Venus is talking about it, the conversation around vaccines came up, and she expressed her hesitancy, and it gave Dr. Zapata an opportunity to express it in a way that clearly took seriously her concerns and her hesitancy. So this is a slide, this is a little bit of a busy slide, but it talks about the reach, about what's the effect of how successful were we at reaching individuals. So our Latinx posts with the Latino Health Council on their Facebook page has over 700 followers. You can look at the Twitter on the right-hand side of your screen. The Twitter L, it refers to Latino. We had 75 posts so far. We've had 41 posts on Instagram. Over 2,000 impressions. And forgive me, I'm not real familiar with a lot of these social media platforms, but basically we saw a really great amplification with those connection to other networks. Posts for the Black community, we have Venus has over 800 followers on her Facebook page, and she's got an email campaign with several people signed up to follow her through these email campaign. The Oneida is another one where Sasheen had a lot of hesitancy about being out on Facebook, but she has just, her reach has exploded. She now, on the Oneida Facebook pages, has a combined following of close to 15,000 individuals. So remember, she is the one who had I think the lowest media presence, social media presence. And like I said, it's just taken off. So I want to end with a thank you to the amazing team, my co-PIs, Maria Mora Pinzon and Melissa Metaxen, our partners with the Latino Health Council, the Wisconsin ADRC, our funder, our project leads, George Levy and Ornella Hills. They really are the glue of the team. Our influencers, I have to say that they are, it's such a fun group to work with. Our scientific and medical community, our advisors, and we're hoping in some way to keep this going. You think about this could be translated to other health messages, to recruitment messages. It's just been one of these great projects that I've really enjoyed working on.
Carrie, thank you so much for the overview of strategies for disseminating information. I think you're right, it could be transferred to a lot of different contexts and is a really good resource for all of us to understand and use as an example. So last but certainly not least, we have Dr. Sophia Wang, who is an assistant professor of clinical psychiatry at the Indiana University School of Medicine, and she leads the Outreach, Recruitment, and Engagement Core at the Indiana ADRC. Dr. Wang.
Okay, great. Can everyone hear me?
Yes, could you go into presentation mode?
Yes, I will do that. Here's the computer left. All right, great. Well, thank you so much for having me. And I think in the interest of time, we'll go ahead and think about COVID-19 vaccines from the big picture, trying to put everything together, what lessons we can learn as Alzheimer's disease researchers from the current COVID-19 pandemic. And I know this has been a particularly stressful time for a lot of people, but I think I want us to take a moment to realize how amazing it is that we have a vaccine out in distribution. And there's definitely a lot of bumps there that we're going to mention in a few moments, but that back in 2018, Dr. Fauci and his group put out a really nice paper talking about novel vaccine platforms. And if we just take a moment to see, so this is SARS, CoV-2, right? But if we go back and look at 2003, when there was a similar virus, SARS-CoV-1, that took 20 months to make this vaccine. Now, that doesn't even take the trials and everything. And then we can see over the past number of years that the Zika virus got down to 3.25 months. And I just want to note that this is a different platform. It's not the mRNA, but a similar concept as these novel platforms were used. I think I want to emphasize one of the statements that I thought was really important in this talk was that he mentioned that it was really important to exploit modern day technological advances, or else we wouldn't be able to respond to the new infectious disease threat. But I think the amazing thing is that we did successfully respond to the threat from a scientific standpoint. In 2020, we saw that instead of 20 months, like it would have been with SARS-CoV, the original, it took us less than 2 months from the time that the genome sequence was made publicly available. This was the concept that science should just be freely available. And then on March 16th, NIH released a news press saying that the phase 1 of these vaccines were out in testing. So I want to take a minute. We've talked a lot about mRNA vaccines. It is a novel technology in a sense, but not entirely unknown. It's been, talked about for a couple years. But still, I want to show here in this diagram to depict, I think, a really common misperception that mRNA vaccines actually alters people's DNA, and that's not what happens at all. So as we can see in this picture here, this is the mRNA. And then what happens is that we have a special delivery system in which the lipid covering, a lipid shell is put around the mRNA. And if you have gotten your vaccine where you get it, you'll see that originally before it gets diluted, it's a little bit cloudy, and then it gets diluted and then injected into the muscle. And then without going into too much detail, I don't want to make this a molecular biology lecture, it goes to the part of the cell that essentially makes the key spike protein. And that spike protein, as we can see right here, that is the part that the body has to recognize as the dangerous element of the virus. It doesn't actually contain anything that would cause harm itself, but that's kind of the way in which the virus can enter the body. So what happens is that the body recognizes that viral spike protein being produced through the mRNA is a foreign particle, and then the body starts to develop antibodies against it. And after a short period, the mRNA gets it gets disintegrated. But the bottom line is that the body is able to launch this response to the mRNA without touching the DNA in any way. So I think this diagram nicely depicts how the mRNA vaccine works without even touching the DNA. So, just taking a step back from the science, why didn't the COVID-19 vaccine, we're seeing some demand, but why are we seeing so much hesitancy? And I think the scientific community may have underestimated the amount of hesitancy. They thought it was going to be this really, exciting phenomenon. People will be jumping on board. So what happened here? And how did this become a public, health, hesitancy, not only just for these underserved groups that understandably have all this mistrust, but even amongst healthcare workers. I mean, we saw really high rates of vaccine hesitancy among healthcare workers. And the reason was, and we've kind of touched on this briefly, is about misinformation, in which social media, as we can see, is a double-edged sword. On one hand, it can be a great means of connecting for underserved communities, but also has been the source of misinformation. And what makes us vulnerable to misinformation, and what can we learn as Alzheimer's disease researchers more broadly from the misinformation during the COVID-19 pandemic? I think there's a really nice paper put out that I'll mention briefly in the references, but it points to the fact that humans, and if the COVID-19 pandemic hasn't shown this enough, is that we're social creatures. We like to connect to other people. And most importantly, we like to connect to hope. And the idea of misinformation has been an issue for many years. When the 1918 Spanish flu pandemic happened, that too was originally, sort of minimized, but it's because people need hope. And I thought there was a really nice quote that says, if you frame misinformation in a way that gives you hope, it makes you pay attention because it keeps you going. And misinformation has now become such a major problem for the vaccination that Google has actually launched, a $3 million fund. And we'll see if this is even actually enough to fight the misinformation. But I think what we can learn as we reflect back is that misinformation exists even for those who have Alzheimer's disease or those who even have memory problems. And we can see here that the FDA has been fighting all these various supplements and questionable issues. So I want to take a broader look, not only thinking about the COVID-19 pandemic, but how can ORIX play a role in addressing the pandemic of misinformation? How can we researchers help the public feel connected to the scientific advancements? I think it's impressive that we've made all these advances, but how can we work with our societies as ORIX being the connector between research scientists and the community abroad, so that way one day when we do also discover a treatment for Alzheimer's disease, which I'm optimistic we will, it can be accepted and not a similar victim of misinformation as the vaccines have been. So I want to point people, I think, to some useful resources here. This is a really engaging 10-minute video from a JAMA introduction. And I think for those who are healthcare professionals who are looking how to keep up to date on the latest information, I've really found that the conversations with Dr. Bachner, who's the editor-in-chief for JAMA, he almost puts, I think, something out weekly, every other week. For those of you who need CE credits, it's very helpful. I would like to point people's attention to actually two conversations that were really fascinating. They're anywhere from half an hour to 15 minutes each. And the first one was on prioritizing minorities for the COVID-19 vaccine. And it talks about why race was not actually listed as one of the priority groups, despite the unfortunate disparities we're seeing. And I thought another thing that was really nice was looking at having a really candid discussion about the COVID-19 vaccine update with Dr. Monto, who was one of the people who led the approval of the process. And just have a few references here. And I want to take a moment to thank everyone in my center for their support, Dr. Sagan, administrator, as well as the core leaders, Dr. Pasalova and Dr. Gao, who are my mentors on my K-23, and feel free to contact me. But I'm going to make sure that we have plenty of time to answer questions, and I want to thank everyone for this brief presentation.
Thank you so much, Sophia, and thank you to all of the panelists and Corinne. I think with our time, with such great information, we have time for sure for at least one question, and they are in the chat box. And I think it kind of applies to everyone. From David Marquez at the University of Illinois at Chicago. He asks, what are innovative ways to hear from community members who might have less access and knowledge of technology like Zoom during this pandemic?
May I address, Dr. Glover, may I address that?
Sure thing.
So one of the things that we've done in our local community here in St. Louis is I've sometimes talked to people on the phone, believe it or not, which might sound a bit, outdated, but it does work. The other thing that has been done is we actually, one of my mother's philanthropic groups, she's in the Links Incorporated. They did a training on how to use Zoom for some of their older members, and I think that that's helped. Another thing that we've also, that another way to engage is through like my local church here. They have Facebook Live, as well as a conference line that we're able to use as well. So those have been some of the things that we've done. I think with COVID-19, it has changed our elders' way of engaging as well. I know with my mom, like I got my vaccine a couple days ago, and there has been a lot of conversations with her girlfriends over the telephone, like, where do I go get vaccinated? How do I do this? And they've been text messaging me. So I think that, we have to think about those other resources, and our seniors are definitely getting very savvy.
Thank you, Joy. That's great. Also, I see that Carrie, Dr. Gleason, would like to answer another question in the chat box, and that is, could social influences be used for recruitment to research trials? Carrie?
And I accidentally clicked the button. So I'm happy to answer it live. So Allison, absolutely, we would love to see this project continue. It could be something related to recruitment messaging. It could also be influential for other health messaging. So we're exploring other opportunities to keep this good work going and keep this network together.
And looks like we have at least just one more minute. I would like to pose this question, and it may be for Dr. Flatt or Dr. Wang. Can those who are HIV positive safely receive the COVID vaccine? I think this is so important to address.
Jason, want to go ahead?
Sure. I would recommend that they talk to their healthcare providers first about it. I think each person's situation can be unique depending on their health. So I would recommend that. Right now, there hasn't been any research, suggesting that it would be unsafe that I'm aware of. But again, we know that our communities are vulnerable. They may have distrust as well as just concerns about the vaccine and challenges. So they can check out some resources. UNIAIDS has a statement about it, but I think each person should consider their unique situation before making a for sure decision.
Yes, so I concur. In brief, because we're still actually under emergency use authorization, there hasn't been subgroup analyses. This includes HIV, autoimmune, pregnant, breastfeeding women. So at least for pregnant, breastfeeding women, the overall recommendation is to talk to your personal provider because it depends on your other comorbidities. So someone who's HIV positive, well-controlled HIV who's in their 20s is in a very different circumstance than somebody who's HIV in their 60s and has extensive cardiovascular disease, because sadly, many of these HIV patients do develop that over long periods of time, and other, pulmonary diseases and other things. So that really needs to be discussed on a case-by-case basis. It's not just a single diagnostic discussion. So.
Wow, that was awesome. Thank you too. Well, we have 1 minute, so we'll close out here. I want to say thank you to, of course, NACC and Hannah, as well as all of the panelists, Jason, Sophia, Carrie, Joy, and our moderator, Corinne. And thank you everyone for attending. This was great. I think this really makes our case for potentially having a second panel sometime in late February, early March, because we still have questions coming in, guys. So that's great. And I think we can end it here. Hannah, is that okay?
And thank you, Crystal, for spearheading this and running the show.
Yeah. Thanks, guys. All right. Well, happy Friday, everyone. See you soon.
Thank you.
Bye-bye. Thank you.
Bye-bye.
Bye.